It is not unusual for women on any social media platform for perimenopause to see posts or comments like this every day. And posts like this often get comments from other women sharing their personal stories of going through something very similar or way worse. Estrogen and progesterone were both discovered in 1929, that is 92 years ago. Yet in 92 years, we have made very little progress on women's health. As of right now, today, year 2021, most women around the world have never heard the word perimenopause or know anything about this hormone decline that happens after age 35. And if on top of that we add that medical students are not properly trained on women's health, this will continue to be a vicious cycle, and it's not about to end anytime soon. This lack of awareness will only stop when our voices are loud enough and we reach the ears of the medical community so they realize that they need to provide a better education for medical students about women's health so they can provide better care for the future generations. No matter how many videos I make and talk about the subject, I can't bring awareness all on my own. I need you, I need your voice so we can be loud, so we can be heard. I need your voice so no woman ever struggles with perimenopause in silence or without any knowledge about what happens to our bodies after age 35. If I can count on you to join me, please share this video with your friends, your family. Get the conversation started to shine some light on this issue that's happening to women all over the world. If I can count on you and your voice, please subscribe to the channel so you and I together, all of us, can build a stronger community for the future generation. And together we can pave the path for the future generation so they don't have to struggle with any of these 40 symptoms for 10 or 15 years. As much as I'm fascinated by the perimenopausal experience across different cultures, I'm also fascinated by the approach different doctors use in different countries. By no means I'm saying all doctors are bad. There are so many amazing, caring, knowledgeable doctors all over the world. I'm just saying that we need more of them. And the doctor from this video is definitely one of them. On the first day when I was added to Irene's WhatsApp group for women in Nigeria, uh, Dr. Amos was there taking questions from all the women in the group, and there are a lot of them. He was there for hours and he answered every single question with no agenda. He wasn't signing a class, a book, a seminar. He was only there to guide women to share what he knows, and that was it. So I reached out to him and asked him if I could do a video so I can take his knowledge, his approach towards this phase that we go through, and share it with women from this side of the world. Let's start this video with the most underrated challenge we go through during this phase of our lives. For every woman out there over 35 dealing with one, some, or all of these 40 symptoms and hearing about perimenopause for the very first time in her life, there's usually a very confused man who's standing right next to her. God only knows men need more guidance than we do. They have to understand something they will never physically experience for themselves. We need more doctors. We need more male doctors out there to explain this thing to them. So if you have one of those poor, lost souls at home, it would be great if you can get them to watch this with you. So here we go.
Yes, the truth of the matter is it is the same everywhere all over the world. Most men really don't know what women go through, in that critical phase of their lives. Most of them really don't pay particular special attention to that phase of life in women. And of course, you won't blame them because they are not in the medical field. It is the very few in the medical field that have the understanding of what women go through in that phase of their lives. This video, if possible, should be circulated, so men will see and know that there is a phase called menopause phase or perimenopause phase, where a woman experiences symptoms as a result of low estrogen level, which in their reproductive life regulates their reproductive cycle. And because the level declines at that phase of their life, I mean, that phase now I'm talking about the perimenopausal phase or the menopausal phase, that they tend to experience hot flushes. They tend to experience low sexual drive. Emphasis on sexual drive should be made because men tend to ascribe low libido, in women or of any age or at all, to be the fact that they may be seeing another man out there. All right, so we need to emphasize that to them, that there's a phase in their life they will get to, they will no longer have passion for sex. So they will need to give them time. They will need to understand them. They will need to encourage them. They will need to understand them that phase will still pass by. And once that phase passes by, they will enjoy their woman in the long run. All right. We will still need to let them know that the stress level, on the woman at home should be reduced. It's the only one who prepares food at home. If they can get a house help to help her in a way, is good, because this is a person who is already depressed. This is a person whose mood has changed. You now belabor with domestic chores. It heightens the mood swing. It heightens the loss of libido in a nutshell. So they need encouragement. All right, their stress level should be reduced to the barest minimum as much as possible. And then the man should be there to cuddle them. In a nutshell, the woman should not be left alone. The man should bear the burden with her as well. I'm a medical practitioner. I'm a general practitioner with special interest in obstetrics, gynecology, and general surgery. So I've seen patients, with clinical ailments that cut across every aspect of medicine, and with particular emphasis reproductive health. So I've got to see a lot of women with complaints of what they experience, what they pass through, in their perimenopausal and their menopausal period. Issue we have all over the world in medicine is information. Attention is not drawn to that critical aspect of life of women. Most of them don't have the understanding that as they approach a particular stage of their lives, there is a decline in the level of these hormones, in the level of these vital chemicals that regulate the reproductive system in their body. And so they tend to come down with the symptomatology, which in a nutshell, the symptoms and the signs of menopause. But I'm sure with this movement, the menopausal community platform, that is established by some wonderful women like yourself and Barrister Irene, I think, in the long run, the gap will be filled, and women will get enlightened on what to really expect, in that when they approach or when they are already in that phase of their lives. In the medical world, there's a challenge. There is a gap that is yet to be filled in enlightening the public, in enlightening the women on what to expect, right, in that phase of their lives. It's true. You see, the thing we should understand in this phase of life, in women, is most of the symptoms those who are symptomatic present with are not in any way different from general conditions that apply, that are common among the elderly. All right. And of course, except one is vast, except one has vast understanding, vast knowledge, of what women really go through in that phase of their life, the diagnosis tends to be missed. We tend to miss the diagnosis. All right. In a nutshell, it is underdiagnosed. You will come, you see a woman with joint pains, perhaps, of the lower back, of the knees and of the elbows. You just, may not think along the direction of perimenopausal or menopausal symptomatology, right? You may just think, oh, this is lumbar spondylosis, for instance, if it is, problem with the lower back. So we tend to underdiagnose it. As a GP, for instance, if you are not so experienced enough, you tend to find yourself in a very dilemmatic situation as to making a rational diagnosis. The estrogen level of a woman in her reproductive life plays a very crucial role in what she will experience when she approaches, the menopausal period. There are some individuals, there are some women that have naturally, they have low level of estrogen, right? There are some that have high level of estrogen. For those with low estrogen level in their reproductive phase of life, as they get to menopause, they may not really experience the severe symptoms that come with menopause. As menopause approaches, there is a sharp decline in the level of the estrogen, and so they present the symptoms. Hot flushes, night sweat, reduction in libido, vaginal dryness, pain during sexual intercourse. They come with headache. They just come with a lot of them, joint pains, joint aches, psychological disturbance cannot be excluded. They are irritable. They have problem with sleep disorder. They get depressed. They just feel their world is coming to an end. So those who naturally have high estrogen level, once they approach menopause, because of the sharp decline in the level of estrogen, they tend to present with the symptoms. The role of antidepressants, specifically a form of antidepressant we call selective serotonin reuptake inhibitors, SSRI. Researchers found that in perimenopausal and menopausal women, the level of serotonin in their system appears higher than the general population. It's believed that the level of this serotonin synergistically works with the low estrogen level to bring about the hot flushes and the night sweat. And that is why most individuals, most women in that phase of their lives do very well with antidepressants, specifically these SSRIs, right? But a very few of them don't do well with them. And of course, they are not medications to hastily prescribe to women. they come with their side effects as well. All right. So what we do, there is what we call expectant management. This has to do with waiting, encouraging the client or reassuring them of a particular period they can endure some of the symptoms to go on their own spontaneously without pharmacotherapy. Some you have to start medication, they have to be on medications for like up to a year, up to 5 years. Some will even have to be on the medication for life, because some of them will end up flushing for life. They will end up having the night sweat for life. And so they will have to be on those antidepressants. It is not because they are depressed, it is the truth of the matter is, apart from the role of serotonin in depression, in mood swings, in irritability, in anxiety, in, perimenopausal and menopausal women, and even the general population who have, depression, it is not that, it is the phase of their life, that is responsible for the irritability or for the mood swing. No, the serotonin level plays a role. The sleeplessness plays a very crucial role. And of course, the sweat and the hot flushes, because you feel something is burning inside of you. You are disturbed. You need help. And somebody will still come to tell you, maybe somebody will come to say something that will exasperate you. Get annoyed. You get irritated. Getting a particular medication that will take care of all of the symptomatology that come with menopause or perimenopause is a very challenging aspect in the medical world, because the truth of the matter is the management of menopausal symptoms in women is actually syndromic, meaning you are managing them based on the symptoms they present with. For those who have pain, during sexual intercourse, who don't get dry, who get dry easily, who have vaginal sores, vulvar sores, who have recurrent urinary tract infection, of course, you will not be giving them antidepressant. You will give them estrogen. Singly manages the symptoms of menopause. Is a thing that will be an impossibility, all right, in the field of medicine, because you really cannot get a medication that will take care of all of the symptoms. There is what you call urethral syndrome. Urethral syndrome means pain during urination that we call dysuria, and increased frequency of urination without proven infection. All right. Such individuals, they will do well with estrogen cream that you will just apply on the vagina or the vulva area. All right. So you see such people, it is not all individuals that come that present with maybe difficulty in urination or excessive urination, you give antibiotics. No. So women in that period, in that phase of their lives, may not need antibiotics, even though they are prone to recurrent urinary tract infection. You need to evaluate, find out if they actually have urinary tract infection, and then you treat appropriately. But most of the times, there is no trace of infection. It is just the change in the cellular, composition of the vagina and the vulva, and the vagina, the vulva, and area, and the urethra, that will not be causing the thinning, the narrowing, of these areas that will cause the pain during urination or excessive urination. Hormone replacement therapy almost always takes care of all of the symptoms that come with menopause. All right. The estrogen replacement, the progesterone replacement. But of course, it has to be individualized at their side effect. Ideally, for individuals who have surgical menopause. Oh, sorry, I should have given an introduction to menopause. We have surgical menopause, we have premature menopause, we have natural menopause, and then we have iatrogenic menopause. The ovaries, the normally functioning ovaries are removed surgically, right? Perhaps, in cases of cancer of the womb, or which you call endometrial cancer or cervical cancer, all right? You remove the oil of the uterus, of the fallopian tubes, and of the ovary. So the individual starts manifesting. For those who will manifest symptoms of menopause, they will start manifesting the symptoms of menopause most of the time within a year or 2 years after operation. So such individuals, you can start the hormone replacement therapy for them. All right. And then you monitor them, until around 60 years of age. But of course, there are some criteria that must be met before the commencement of hormone replacement therapy. We need to find out if the individual has not had a history of breast cancer. We need to find out if the individual has not had a history of endometrial cancer. Right? We need to find out if the individual is hypertensive. We need to find out if the individual has had coronary heart disease. If we need to find out if the individual has had what we call venous thromboembolism, right? We need to find out if the individual has had migraine, existing infections such as hepatitis. All right, we need to establish, exclude all of this before such individual is commenced on hormone replacement therapy. Ideally, combination hormone replacement, estrogen and progesterone, is the ultimate in their management. If you give estrogen alone will protect the individual from breast cancer, but exposes the individual, the woman, to endometrial cancer. If you say, okay, let me just give, this woman does not qualify for estrogen only therapy, let me give progesterone. You give progesterone, of course, it will protect the woman from endometrial cancer, but in the long run, she will suffer from breast cancer. So it is really a very dilemmatic situation, administering hormone, in the management of menopausal symptoms. It has to be individualized. So the only medication that will ultimately take care of all the symptoms perimenopause and menopause come with is hormone replacement therapy. And of course, it has to be individualized, because you wouldn't want to manage symptoms of menopause and in the end, the individual dies of endometrial cancer or breast cancer. Not all hormones that are synthesized from the host urine. All right, the hormone that basically we get from host urine, human placental lactogen, we call human chorionic gonadotropin. It is not what is used in menopausal or perimenopausal women. The estrogen and progesterone that are used are actually synthetic forms. They are synthesized from various biological reactions, right? So they're actually not natural. There's natural hormones that are found in us. The estrogen, the progesterone, they're found in us. But there are some that science, as a result of advancement in science, in medical science, we have synthetic estrogen, synthetic progesterone, and they are safe. if and only if there are no contraindications to use in such women. For women who are undergoing menopause, perimenopause, they still have some level of protection from the little estrogen in their system against osteoporosis. So osteoporosis tend to set in after about over 10 years up to 20 years post-menopause, all right? So ideally, giving them medical supplements like calcium, like bisphosphonates, like strontium, right? Like even raloxifene really is not needed before, it's not needed in early menopausal years, because their bone mineral density is still optimal, except in a situation there is a risk factor. There's already a background risk factor for osteoporosis, such as previous fracture, congenital, that is bone defect they are born with. To such individuals, you can start them on, medications that will check osteoporosis even as early as the first year post-menopause. But once there is no risk factor for osteoporosis, you don't get worried about, osteoporosis so long as you are within 10 years post-menopause. All right, you tend to think about taking, supplements, that will help in bone mineralization, after about 20 years post-menopause, because your bones are still strong. And of course, exercise is very important. Diet alone and exercise are very crucial. As a matter of fact, before menopause, before perimenopause, one should not underestimate the quintessential role healthy diet and exercise play in the health of one. The perimenopausal and menopausal women who will present with symptoms of low estrogen level complain of low back pain, complain of pain of the wrist, complain of knee pain. All right. So exercise is key in such situations to maintain the mobility of the joint. Diet is key as well. Low-fat diet, and as a matter of fact, we encourage weight loss, because whether you eat or not, menopause brings about incremental weight gain, at least 1 kg per year. So if you do not check your diet, you are at risk of obesity, and obesity will even worsen the symptoms that come with menopause. The risk of stroke will increase transcendentally. The risk of coronary heart disease will increase transcendentally. The risk of osteoporosis will even increase. And of course, sleep disorder will set in. Diet, very important. Low-fat diet, very key. We encourage them to take more of high-fiber diet. Take veggies, take fruits, right? Very, very important. And then for those who are not taking adequate calcium in their meal, we encourage them to take calcium supplement. We have 4 basic forms of estrogen. We have the estrone, we have the estradiol, we have the estriol, we have the estetrol, respectively E1, E2, E3, and E4. The one that plays the role of reproduction, of modulating the reproductive cycle, is the estradiol. It is the reduction of the estradiol that comes with the symptoms of menopause. All right. Now, the estrone is produced more from the fat cells. As a matter of fact, it is implicated in obesity, in perimenopause and menopause, and perimenopause and menopause. So the level of estrogen increases in menopause, but it does not check the effect of the low estradiol level. Estradiol is another hormone. It is exclusively produced by the placenta. It plays a role. It is the highest circulating hormone, estrogen, during pregnancy. So in a nutshell, estradiol, and even estradiol that are produced in some vital cells of the body don't play any role in regulating, or modulating or reducing the effect of menopause. It is the estradiol, which regulates the reproductive cycle, that declines in level, in quantity at menopause, and now comes with the symptomatology of menopause in women who present with symptoms of menopause. If you look very well at those supplements that are in the market everywhere all over the world, they are all multivitamins. Vitamin A, vitamin B, vitamin C, vitamin D, vitamin E, all of them. And the truth of the matter is, we have most of these vitamins already in us. A lot of them are stored in the liver, a lot on the skin, a lot in the kidney. They are distributed in most tissues, in most systems, in most organs of our body. And the body has a large reserve of these multivitamins. And as a matter of fact, we get them from the food we eat. We really don't need these multivitamins. Multivitamins abuse in peripheral neuropathy. Peripheral neuropathy is a dysfunctional sensation of some parts of the body to stimuli, and it is characterized by tingling sensation, numbness, paresthesia, peppery sensation. It is implicated that abuse of multivitamins plays a very crucial role in the development of that medical condition. Hypertension, liver problem, vitamin B12 deficiency are very common cause of peripheral neuropathy. Another common cause is vitamin B6 toxicity. Commencement of the enlightenment should even start before age 35. Emphasize the role of diet. The role of exercise should be emphasized as well. You need to let them know that, of course, it is important they go for regular pap smear, because most people who approach menopause, they actually, at the risk of cervical cancer as well. So emphasizing screening for cervical cancer is still very important in that period of their life as well. Women who are overweight, most of them naturally, they tend to have an incremental level of the mood swing. So the irritability will be worse. The sleep problem will be worse. The depression will be worse. And the night sweat will be worse. Obese women tend to sweat more. So with low level of estradiol, there will now be at least about ×2 of sweating capacity. So their sweat glands tends to produce more sweat. It is the estrogen level that plays a role in weight gain in women. It is the estrogen level that that is responsible for the weight, for the accumulation of fat cells in women at menopause. high level of estrogen at menopause, one, women tend to add more weight. And so those who are fat, naturally, they already have high level of estrogen. So at menopause, the level of estrogen rises more and they add more weight. Exercise is very key, and dietary modification, lifestyle modification. If they are sedentary, we encourage regular exercise. We advise them to stop freak dieting. If they take alcohol, we advise them to stop alcohol intake. If they smoke, we just encourage, they just have to stop it, because this thing is their health. Somebody who has calm disposition, who is ebullient, always happy, all of a sudden, because of the transitional phase she has got to, she now becomes withdrawn, irritable, depressed, and most of the times unhappy. Everybody will be worried. As a matter of fact, there are some people in the psychiatric world today that are not really psychiatric patients, but because they are passing through that perimenopause or menopausal phase of their lives, they have heightened symptoms of depression, and so they have to find themselves in the psychiatric world to be managed by psychiatrists. If women have the understanding of what to expect at menopause, there wouldn't be need for hospitalization for any management of depression in the first place, because they're already primed to what I expected. And then the ones they are coming, they easily know how to meet their GP or their gynecologist to institute appropriate therapy.